Great. Hi, everyone. I'm Scott Podolsky. I want to welcome you all back to our Department of Global Health and Social Medicine seminar series. One of the enduring highlights of our series is our ongoing opportunity to host the Master of Medical Sciences in Global Health Delivery Alumni and Action Talks. And we have really remarkable alumni, as you'll see today. We, of course, would not have such alumni without the program director of the MMSc, Dr. Joya Mukherjee. Dr. Mukherjee, as I'm sure all of you know, is Associate Professor of Global Health and Social Medicine at Harvard Medical School and Associate Professor of Medicine in the Division of Global Health Equity in the Department of Medicine at Brigham and Women's Hospital. She teaches infectious disease, global health delivery, and human rights to health professionals and students from around the world, and she'll have the opportunity of introducing our speakers today.
Great. Thank you, Scott, for that kind introduction. I'm just so delighted to be able to introduce almost Dr. Aneel Brar. Aneel is from Canada originally, but his family has deep roots in Rajasthan, India, and his family had started an NGO called Mata Kaur after a family member who herself died during pregnancy. And he elevated the small town of 35 BB in Rajasthan, named for the place it was on the canal, part of the canal system there, to really highlight the structural violence against women. And what I think Aneel has done very uniquely as a man and as a person living in the diaspora is tell the stories of women and allow for the voice of women in both the ways that they're succeeding and the ways that they are suffering. And I really felt that Aneel's master's thesis, which was concerning the structural violence and agency in for women in that area in 35 BB, and access to reproductive health services, was a very strongly feminist lens, and really looking at the world through the eyes of women in a very dominant patriarchal system. And so it was a remarkable kind of work that Aneel did for his master's, and we were all thrilled when he went to Oxford to get his PhD in medical anthropology, and he's back here with a couple of colleagues. Welcome, Sumya Singh, to talk about the work in looking at maternal perinatal depression or maternal depression and gender-based violence. So the extension of that great work from his master's into his PhD. So Aneel, almost doctor, take it away.
Thanks, Joya. So hello, everyone. Really, thank you for having me. It feels like coming home whenever I do one of these, and I've done these once before, so both times it's felt like home. And of course, this is because I've learned so much from everybody here. So many people in this department have shaped the way that I've thought about and engaged with my work. So I kind of said this at the Friday morning seminar, if anybody was there, so forgive me if you're hearing this twice, but I do feel such a debt of gratitude to the department. And so just want to thank you all and thank you for coming out. So a couple more shout outs before I start, because there are a lot of people I've also learned from who are attending this, although I can't see your faces right now. So in addition to you departmental types, there are people on the call from Goa, India, so specifically Sangat, which is Vikram's group in India. So I'd like to specifically kind of shout out to Abhijit and Urvita, who are on the right side of this image here. So Abhijit and Urvita have been really special champions for me, and I can honestly say that none of the work that's presented today could have happened without them. They're just kind of unique researchers and epidemiologists who have really championed service. And then on the other side, my two colleagues, and Perinatal, good to see you on here, Samya and Perinatal, on the extreme left of this image. So they've become sort of they're the first kind of long-term researchers other than me that have lived in my rural site and have become sort of the lead researchers on much of what you saw, much of what we're going to show you today. And they came from urban centers, so Delhi and Jaipur specifically, to brave the village life with me. And so I'm very proud of them, and also grateful for them to also be two of my teachers. Okay, so I'll just start with a mention of our location. So on the left here, you see a map of India, and the state of Rajasthan is at the northwest in blue, and our district is the little pink area, and that's called Ganganagar. And then, as Joya mentioned, I run a nonprofit called Kaur, and to the right is just an image of one of our Sunday outpatient clinics where women from the region come and get healthcare from us. And so MJK's mission, Kaur's mission, is to provide high quality maternal and reproductive care to women who wouldn't otherwise get that care. And this is just a beautiful kind of full team shot that I thought I'd show you guys. Okay, so what we're going to talk about today are two extensions of that core work that we're doing. One of them is a perinatal mental health program called the Khushi Mamta program. Khushi Mamta translates into the Happy Motherhood program, which is a lay counselor delivered perinatal depression intervention. And then the second program, which was an extension of the Khushi Mamta program, was the Men Against Violence project, which Soumya and Prerna were more directly involved with. So I'll talk about both of these. It'll be a kind of a quick survey, but I'm happy to get back to questions at the end about these two programs. Both of these programs were disrupted by COVID-19, but like everybody here, we've adjusted and it kind of delayed a few things. So some of the data collection is pretty recent, and we're going to be presenting kind of preliminary things, but we managed to get through it, and it actually showcased the resiliency of our lay counselors as well. Okay, so Khushi Mamta program. I'll give you a quick narrative about how this program came about. The long story short, there's kind of two narratives here. The long story short, which is the more personal narrative, is that this baby on the right, her name is Khushi, and she was the daughter of one of our patients who came in with severe depression. And so to make a long story short, she basically inspired us to look more into perinatal depression. And her name is Khushi, which means happy. So we named our program after her. So the KM program, or the Khushi Mamta program, is essentially an adapted version of the Thinking Healthy program, which is part of the WHO's Mental Health Gap Action Program, or MH-GAP for perinatal depression. So a lot of the people in the department are pretty familiar with this story of the movement for global mental health. For people who aren't as familiar, I'll just simplify. Recently, through various metrics as part of the global burden of disease work and DALYs, we were able to identify mental disorders as a significant and significantly underaddressed form of suffering, especially among the most vulnerable across axes of gender, race, income, and caste. And through being able to measure this, we were able to discern pretty significant treatment gaps. So in India, it's estimated that 90% of sufferers don't get adequate care. So sufferers of depression or other mental disorders. And this is largely due to a lack of specialists or public funding or governmental support, just kind of everything. And as Vikram says, this is not unique to India. Everywhere in the world is a developing country when it comes to mental health care. So the idea then is to fill this gap with lay counselors, right? To increase the workforce, to have them take on functions that a specialist might otherwise do, such as identifying sufferers and actually providing counseling. So this is a deceptively kind of simple, but it is a profound idea. But I must admit that what attracted us to this idea was, or this model of care, was a bit more instrumental. So I actually saw the Thinking Healthy model, or the lay counselor delivery model, as a way to identify vulnerable women who we could not currently get to attend our clinic. So we just knew that there are many women out there who were isolated, who, we were a rural-based clinic, and the idea behind that was to provide something that was comfortable and easy to get to. But even with that, we knew that there were just women that we couldn't meet. So we thought that having a cadre of lay counselors could provide the opportunity to take that extra step towards them. So that was the initial thinking for us. Yeah, and and of course, the statistics around mental illness themselves are troubling and compel action as well. So just to give you the sense of, and something that I think more about, and I'm kind of addressing more in my anthropological work in my PhD thesis, is around suicide. And so just to give you the stat of suicide, which always stuns me whenever I hear it. So suicide is the #1 killer of women aged 15 to 24 in India, which are the prime ages of pregnancy and childbirth. And yes, 15 is an age of pregnancy and childbirth, and we'll get back to that. Okay, so just a little bit of background. The original RCT that kind of tested the idea of the Thinking Healthy program, or the cognitive behavioral therapy-based intervention provided by lay counselors, was done in 2008 in Pakistan by Atif Rahman. And it showed an enormous effect size. They used actually an existing cadre of community health workers. And that work eventually led to the development of the Thinking Healthy program manual, which was adopted by the WHO. So more recently, the THP was modified into the THPP, which is the peer-delivered version of this program. And basically what they did was they kind of simplified the manual and emphasized the behavioral aspects of CBT over the cognitive aspects. And there'll be other people on the call who can maybe talk to this a little bit more precisely, but I believe why they did this was to make things easier and more straightforward for the counselors, just to make the concepts easier. So peers in this case were defined as women who were similar to the profile of the woman targeted for the intervention. So these were mothers themselves, slightly older, of the same community, but notably of kind of like higher social status, which was thought to give them access. So pretty recently, these two versions of THP were trialed, and this was led by Vikram in Rawalpindi, Pakistan again, which is somewhat similar to our setting, and in urban Goa. And so this was interesting. The effect size of these two trials was a little bit less. So the one in Pakistan actually showed no effect size. The one in India showed a moderate effect size. Nevertheless, I think there's, besides these, I mean, in addition to these RCTs, there is a really robust growing body of evidence that supports this model. Yeah, the question though for us was, there's this RCT modeling, there are these metrics, there are these articles in the Lancet, but there was a question that puzzled me about this, and that was, why hasn't a lay counselor delivered perinatal mental health model been integrated into any kind of national healthcare system? It hasn't really been scaled up despite kind of the strong evidence behind it. So for us, the question was really, it's an implementation question. How do you actually implement this? Is there like a bottleneck that is preventing this from really expanding? And this work is expanding, and I might be wrong, maybe it is starting to be integrated somewhere. So, and if anybody knows about that, please let me know. I do know that this model is being trialed in North America. So it's a pretty neat kind of thing. So for us, the work started in 2018 when we went through several months of community consultations, recruiting, training. And through that whole process with the counselors themselves, we were able to adapt the model to our setting. And actually, the process for us of adaptation extended throughout implementation. So everything from how the counselors engage the patients, how they travel to villages, how much they get paid, supervisory practices, all of this got tweaked throughout the kind of 2-year implementation. Here's a picture of a training. This is when it's a little bit chilly in Rajasthan, but kind of sunny. And this is our team of counselors who've just gone through the process of one of the training obstacles. So it was a proud moment for everybody. So our research question again was an implementation question. It was, can a community-based lay counselor delivered maternal mental health intervention be sustainably implemented through an existing maternal healthcare delivery platform in rural Rajasthan. And our aim was to evaluate this over 18 months. And this got extended a little bit because of COVID. And so we used mixed methods. We used survey tools, interviews, focus group discussions. And again, our primary outcomes were things like acceptability, feasibility, appropriateness, and the secondary outcomes were changes in depression scores on what's called the Patient Health Questionnaire. So the Patient Health Questionnaire, PHQ-9, it's a short screening tool that you can use to identify people who are suffering from depression. So we wanted to see how that changed over time. And also another scale that we used was the multidimensional scale for perceived social support. So part of the theory of this program is that you increase your psychosocial, so the social support around you, and hopefully increase the perceived social support. So that was something that could be measured as well. And just to give some preliminary outcomes, and I'm happy to talk about this a little bit more later. So secondary outcomes first, and a caveat with this, this is kind of like recent data, so kind of a preliminary rough presentation. And also, because this wasn't an efficacy trial, we don't have a comparison group, but I want to talk to Vikram and some others to see if we can get a meaningful comparison with existing trials. But the most important thing, and I think that is the thing that is the most outstanding and shocking, quite frankly, is just the number of women who are screened by our counselors. So we had 10 counselors. They screened 1,290 women. This is over about 10 months. And they went to 155 rural villages and towns. And that just kind of reach is astounding to me. Nobody dropped out. The fact that these women were able to go and do this, some of them were very young, some of them, this was their first job, is just something that is really astounding to me. And then they found 161 women who were depressed and were willing to be enrolled in the program. So 19 out of that 161 had moderately severe to severe depression. And the average number of counseling sessions that we gave were 6, but one of our adaptations was to allow for more or less counseling depending on the person. And the maximum that we gave one person was 20. The minimum was 2. Okay, and then in terms of PHQ-9 change over time, 86% of our patients improved in their PHQ-9 scores and 64% improved in the multidimensional social support scale. Okay, so I'm gonna try to talk a little bit about, this is just more kind of to provoke than to really get into our specific findings, but some lessons that we found from this intervention. So first, the first lesson was to really trust the counselors. And again, I'll just reiterate that like some of these counselors, for us, the profile was a little bit different. So they weren't, half of them were mothers, half of them were unmarried and childless women. And we made no kind of bar for level of education. You just kind of had to be, you had to be able to read, but you had to kind of have the instinct to be a counselor. And they became experts. It was really, really remarkable to see. So I think the term lay, in lay counselor is kind of a misnomer. So concepts such as consent, privacy, non-judgmental listening, these were all very difficult and like new concepts, but they were all able to get them. They were all able to become professionals. They were all able to develop the technical skills to use the screening surveys and those kinds of things. And all of this was new. So it was just an incredible transformation. And I say trust the counselors because, one of our adaptations, the significant one, was that, going from THP to THPP, it seemed like that change was to make it more prescriptive, right? So the Thinking Healthy peer delivered version, which is the latest one that they trialed, was very, very prescriptive. It was very, very step by step. And, for us, we kind of let the counselors be a little bit more instinctive and use their judgment. And we trusted them essentially. So our version is kind of more back to THP. Okay, and another lesson, and I think this is an understudied part of this, although there is a recent paper by Abhijit and Sheena Wood on the effect of this kind of program on counselors. But a really important lesson here was the transformation and empowerment of the counselors themselves, which is, which again, I worked with these women over 2 years, and just to see that kind of transformation is something really to notice. Oops, sorry. And then the other interesting thing was the mechanisms of change. So within this, so part of one of the strategies to change unhealthy thoughts and behaviors was to emphasize nurturing of the baby, right? And this is especially important if it's a girl, right? Because in this context, having a girl is a risk factor for depression, right? People generally don't want girls. But if you can encourage the mother to think about the baby when it's in the belly and really engage with the girl when it's born, it really kind of changes something. And this is from patient interviews themselves. A lot of them just thought that this was such a novel idea to be able to listen and play with and interact with a newborn baby, especially if it's a girl. And then simply just having someone to talk to. As you'll see in our next section, a lot of women are very, very isolated. And so just having someone to go and talk to and be a support and just come and listen to your problems was really helpful. So there are some pretty significant criticisms, I think, of this program that I hope that we can address and that are important to shed a light on. One of them is the ethical dilemmas around this kind of engagement. So I'm happy to talk about this more, but you can tell from the suicide stats that I gave you earlier, many of the encounters that our counselors had with patients involved suicidal ideation, right? So we are kind of putting our counselors in this setting where they're exposed to the trauma of someone who wants to self-harm. And, in professional settings, we would never let a psychologist or a psychiatrist experience that and then not themselves have support. And we don't have that kind of support for these counselors. So we're putting them in these very difficult situations. A second thing is the limited scope of this kind of program. So it's quite frankly a very neoliberal program, right? You're going to the sufferer, in this case, the mother who's suffering from depression, and trying to get her to change her own thoughts and behaviors without necessarily thinking about the bigger structures around her. And one of the things that we noticed that was out of the control of this mother was the experience of violence. And it was just so profound, more than I'd ever really thought before starting this program. And so that motivated us to think more deeply about gender-based violence and how it exists in our program. In our setting. Okay, so this is what led to the Men Against Violence project. And I'll just mention that we got funding from this from the Center for Global Health Delivery, so at Harvard Medical School. And I really want to thank Salman Keshevji for that support. And of course, this was in collaboration with Sangat. So what I'll do now is I'll turn it over to Soumya, who's reaching us from Goa, and she'll take it from here.
Thank you, Aneel. Thank you so much for such a kind introduction and for introducing the program. So I'll just briefly go over the project aims and some of our research questions. One of our major aim was to develop a culturally relevant male-led intervention for gender-based violence in rural Rajasthan. And why we wanted it to be a male-led intervention is something that Aneel has discussed. We realized that the engagement of men in Khushi Mamta program was really low, and we wanted to encourage men to be allies in a gender-based violence prevention program, and hence the idea of a male-led intervention was born. Secondly, what we wanted to do was examine the intervention's acceptability and feasibility within the local context, and finally change local attitudes about gender-based violence and reduce the experience of gender-based violence among local women. However, we face certain challenges related to ethics, and we face certain challenges related to COVID-19. And due to that, within the given time frame, we were able to develop the intervention draft, but not examine its acceptability and feasibility. However, we will be presenting the intervention draft to all of you at the end of this seminar. Now, coming to some of our research questions were One, what are the local perceptions, experiences, and understanding of gender-based violence? What are the possible avenues of prevention and intervention? And who might be effective agents of change? Now, coming back to the discussion that we had about Khushi Mamta, from where we stood, our starting or motivating idea was that these agents of change could be self-identified reformed perpetrators of violence. So basically older men who were violent towards their wives but had reformed themselves over the course of time. And we realized through the Khushi Mamta program that these older men had enough social capital to lead a primary prevention program that involved men. Anil, next slide, please. Yeah. So just to give you a little context about where we were working, in our context, we knew that the conditions of violence are very much associated with marriage. So that's why we focused on married couples. Marriage, we knew, could set conditions for many forms of violence, including physical, emotional, sexual, and financial. And in India, 99% of women are ever married. So making India one of the countries with the highest rates of marriages in the world. And despite having legal restrictions on the age of marriage, which is 18 for women and 21 for men, about 20% of Rajasthani women are married by the age of 15 and 33% before the age of 18. So what happens really after such a young age of marriage is that the young bride is expected to begin bearing children. And over 1 in 5 Rajasthani women between the ages of 15 to 19 have children. So this early age of marriage, coupled with the burden of having to bear children at such a young age and living in a largely patriarchal socio-cultural society, puts young women at a very high risk of experiencing gender-based violence within the confines of marriage. In fact, in Rajasthan, over 82% and 92% of all incidents of physical and sexual violence against women are perpetrated by husbands. So you could imagine that violence and sexual abuse are experiences that for many adolescent and young women living in Rajasthan are experiences that are deeply embedded in their experience of marriage and are associated with common mental disorders among young Indian women. Coming back to something that Aneel had previously mentioned, it is important to note that almost 40% of women who kill themselves globally live in India. With that, I'll ask Prerna to take over to talk about the study design and our methodology and some of the research findings.
Perinatal, you just unmute yourself.
Sorry. Hi, thank you, Aneel. Thank you, Soumya. Here I'll be discussing about the study design and the participants' characteristics, along with a case study that we found in our field experiences. So this was a formative research program. We used qualitative methods to collect data from community stakeholders to understand how gender-based violence was perceived and experienced to inform the development of an intervention program. We used purposeful sampling to gain broader perspective of intervention groups and communities. The research team conducted 40 semi-structured interviews, which included 21 young married women, 17 young married men, and 2 local government officials. We also conducted FGDs with potential agents of change and community health workers, respectively. Prior to data collection, we conducted theory of change workshop with potential agents of change, which were older men above the age of 40 years to check our preliminary assumptions. And we also used Khushi Mamta program as the pre-existing platform with the help of lay counselors as our ambassadors for social capital within the community. It was important, however, to keep a strict separation between Khushi Mamta program and MAV project. So ethically, the greatest concern was that our questions would increase the risk of harm to the participants or their partners. So that's why we did not include any patients of Khushi Mamta or pregnant women within MAV project. So ethical practices to reduce potential harm included interviewing only men or only women from one village or the given community to reduce potential misunderstanding or breach of confidentiality that could lead to further violence. We provided resources to all the interviewees so that someone they know, or if they are suffering from gender-based violence, they can seek help. So time taken during the pre-data collection and to establish the rapport within the community members, to test and refine qualitative interview guides, and to devise protocols to ensure the comfort and safety of both the participants and our field researchers was about 3 months. So the participants' characteristics were, we collected data from the young married and young married women within the age of 18 to 30 years who could produce their Aadhaar cards, which is a unique identification document in India. So the level of education within the females was found very low. Almost about five women out of 21 were never educated, whereas all the men were educated above the primary level education. 2 women have had love marriages. Otherwise, all the participants have had arranged marriages within the participants among the community. 26 participants were from the lower caste, 13 participants were from the upper caste, and we also interviewed 1 Muslim woman. So I would be discussing about the major themes which illustrated during our work. So we collected data, and after that we transcribed and translated them translated the audio recordings, and after that we analyzed the data using NVivo. The major themes that we found helped us in developing the idea about the experiences and perceptions, and they directly informed the intervention design. Rather than presenting all the themes here, we will be presenting just a few cases to illustrate the complexity of gender-based violence in our settings. So few of the themes that we have mentioned here are related to restrictive norms around marriage and sexuality, social isolation and invisibility, normalization of violence also. So I will be talking about this one unique case which the participant I interviewed, and she was a previous patient of Khushi Mamta program, and she had benefited a lot by the visits of our counselor. So she was a 20-year-old mother of a 2-year-old. She was living in a border village in Rajasthan, in a village where the culture of violence was highly normalized. So, and she was married twice by the age of 20. So first time she was married, she was 15 years old, and she was divorced within 10 days of marriage as her family was incapable of giving dowry to the groom, which was a motorbike. She would happily recollect those 10 days of her marriage as that man was at least not violent with her, unlike the second and the present husband. So she belonged to a lower caste and was married in a dominant upper caste group, which was quite unusual for our settings. She had reproduced a son, and the son was taken away by the mother-in-law, stating that she belonged to the lower caste and she is a dirty blood. So I will be talking with the, Anil, can we please look at the quotes? Yeah. So to highlight the themes from the interviews, I'm going to read out the quotes which came up in our interview. My mother-in-law used to come to our room and ask, "Why are both of you fighting?" And he used to openly say that she does not have sexual intercourse with me. My mother-in-law said that this is a custom which has to be followed. She used to taunt only me. She never used to say anything to him. She never asked him that why do you force her to have sexual relations with you? So this participant did not have any sexual agency, and she would often talk about sexual coercion and marital rape. And she also provided us with the dialogues and the taunts which were said by the mother-in-law or the other family members, which highlighted the sexual entitlement of a man in our settings. The other theme that came up was social isolation. Whenever I talk to my grandmother on the phone, he doesn't let me talk to her ever. Earlier, I had a phone. My mother and all had given a phone to me. They talk to me, but he doesn't let me talk to anyone. He told me that you are not going to talk to anyone, so he broke that phone also. He said that I will not let you talk now. He broke my phone, and neither does he make me talk to anyone, nor does he let me talk. So she was quite isolated within the community, and she would always she would talk about that she can live without food, but all she wanted was someone to talk to her affectionately, and as she was feeling very lonely. And but she would stay there inside that house despite of the kind of neglect and the abuse that she was facing, so that she could at least see her son twice a day to breastfeed him. So my mother-in-law is very cruel. I had a water container. She took that away from me. She did not give me anything to have water in, not even a bowl. I used to drink water in the cap of a bottle. My mother-in-law also said that she is black, like a kitchen utensil. Why would men watch her anyway? Not only she was neglected by the family and the husband, she was also constantly made to feel inferior because of her complexion. And the husband would often harass her that if she goes out, then the other men are going to look at her. So he locks me in a room, and if I speak to anyone about the abuse or call someone for help, he shuts my mouth and keeps his hand on my mouth. So the husband was very violent, especially under the influence of alcohol. He would keep a stick outside the room, and whenever she would deny him of the sexual intercourse, he would shut her mouth and beat her with the stick, and nobody would come to help her. Even if she would tell the mother-in-law would favor her son, saying that this is his right to have sexual intercourse with her. So, and hereby I hope that as our work kind of helps and supplements the larger perspectives we are looking at. And I really thank Howard for funding our project. Thank you. Over to Soumya.
Thank you, Prerna. I would also like to present some of our findings using personal stories of two women and how they experienced and conceptualized violence in their daily lives. Reena, one of the women that we interviewed, was a 24-year-old woman. She was a Nayak woman. A Nayak woman in our context is a low caste woman, and that is important to mention because caste in our context is a structure that largely influences the socio-cultural environment of an individual. So she was a Nayak woman who had completed primary schooling until the age of 13. She was married to a man who had alcohol problem, and she was mother to two children, one of whom was affected by physical disability in the legs. They lived in a tiny mud house the size of a room with no separate kitchen, no separate bedroom, and a washroom 50 meters away from the house. She, along with her 8 sisters, were married one after the other and sent off to different villages where they had very little social support and very little safety net. When Reena spoke about her experience of violence took many forms. Physically and sexually, she recounted beatings and rape that were aggravated under the influence of alcohol. Again, contextually, that is, alcohol use and misuse is a problem that's highly prevalent in the villages that we were targeting. Socially and financially, she was denied basic resources such as food and money to be able to feed her family, and also something as simple as a means of identification, which is an Aadhaar card, something that would allow her to receive government incentives, such as a monthly ration for groceries, something that she was in dire need of. Even when she did receive government incentives, she hardly ever had access to it. So, for instance, at the time of her second delivery of a girl child, the couple received 6,000 rupees, and that she wanted to use for her son's treatment, but instead was taken away by her husband. So she had no access to resources, and she had very little access to social or legal support as well. because contextually, this experience of violence is considered the norm. It is considered the norm for any woman who has married a man who drinks, has to go through. So this was a story of Reena, who was a 28-year-old Nayak woman living in a tiny village. Another story, which is similar and but quite different in a lot of ways, is of another woman that we interviewed, who was an upper caste 24-year-old woman who had completed her master's in computer science. The story is different in terms of how they experience, how Reena experienced physical and financial violence, but the other woman did not. But their story was also similar in a lot of ways. She was married to a man she never knew because her parents suspected that she had a romantic relationship with a boy. And she got pregnant the year she was supposed to write her final exams. And in her own words, she felt that that was the greatest act of violence against her. She was also sexually coerced, and she gave into that in order to avoid conflict and avoid being called terms such as a eunuch. So now these two stories may be very different in terms of where these women come from, but their stories also point to some of our major themes that cut across different groups of women, across different groups of women who had diverse educational attainment and who came from different income groups. The first similarity between these women was how they conceptualized violence. In this context, they never described sexual coercion as marital rape. They would describe it as something wrong. They would describe it as a difficulty, a difficult time, but they would never call it marital rape or violation of their sexual rights. They would call it a difficulty that is caused by men's natural sexual drives. Emotional violence, such as degradation or humiliation, was seen as men getting hyper or angry, but it was never seen as emotional violence as such, or someone violating their dignity. So these stories reflect similarities in how they conceptualize violence, and then they also reflect a similarity in the lack of agency. Women did not, across groups, did not have agency to decide who they marry, when they give birth, and when they consent to have sex. These are decisions that are very central to a woman's life and body, and these decisions were not in their hands. And despite this violence being so pervasive, help seeking was very low among women, because another thing that was very common was the lack of faith in health providers. This lack of faith stems from reasons such as victim blaming at the community level, at the sarpanch or panchayat level, and attempts at reconciliation by health workers, psychologists, counselors, psychiatrists, people who are there to provide mental health care services to these women. So when I talk about these themes of lack of agency, not seeing violence as violence, normalization of violence, and not being able to talk to anyone about what they're going through, ties back to the major themes that we talked about earlier in the seminar, which is restrictive norms around marriage and sexuality, social isolation and invisibility, and normalization of violence. Before I move on, I would just like to read one of the three quotes that's put here, and is very telling of how women conceptualize violence in their daily lives. My sister's married life is quite the same. Everyone's husband gets drunk the same way. Everyone beats their wife. Which husband does not beat his wife? Over to Aneel. Aneel, for yeah.
So thank you, Prerna and Soumya, for those field vignettes. Before I move on to male perspectives, I'll just give a brief reflection on this process of data collection. So as you can tell, we were able to gain some very, very deep and nuanced insight into the lived experience of gender-based violence. And I'll just note that the quality and depth of our data is due to the superb skill of Soumya and Prerna as researchers and interviewers. You can imagine how difficult it was to identify participants and then to safely and privately interview them in a setting where many women, especially those who are suffering from gender-based violence, are quite taciturn. And we were just able to get some incredible detail. The skill of our researchers can also be highlighted for the male interviews. So Soumya and Perinatal were also involved in that, but in order to get that done, we had to recruit another interviewer, Dr. Amit Dage, who I hope is on the call right now. So what I'll do is I'll give you some male perspectives on sub-themes that will contribute to our understanding of the three themes that we mentioned at the beginning: restrictive norms around marriage and sexuality, social isolation, and normalization of violence. So one of the major sub-themes was the idea that in the eyes of many men, there is such a thing as justifiable violence, that there are certain expectations of what it means to be a good woman, and that when a wife deviates from that standard, she invites violence upon herself. So it's basically victim blaming. This includes expectations around sexuality, reproduction, and even interactions outside of the home. So good women, quote unquote, are responsible for family cohesion, and violence is often seen as a justifiable way to ensure control and compliance. So I'll just kind of mention some of these quotes. So family is a big thing, and this is a male laborer who's 29 years old from the region. He says, family is a very big thing. It's not a small thing. It has a very big meaning. The family is good if there are children, and if a wife stays under the man, then it is a very good thing. So this is not necessarily just a class thing. The next respondent was a medical doctor, or he called himself a medical doctor. He says abuse is needed when the woman is wrong in her behavior. For example, talking a lot on the phone or something like that. She needs to be kept under control. And the next example I'll give you is a farmer, 27-year-old farmer. He said, I had observed that one of the reasons for abuse was that the wife's attitude and behavior was not right. So there's a lot more that can be said of the male perspective, but I'll save that for discussion if we want to talk more about it. Suffice it to say that what we're looking at is like a really deep patriarchal system that places women at high risk. So just a couple of caveats before we kind of move on. First, it's easy for these kinds of explorations to become voyeuristic sojourns into another culture. That's not what we're trying to do. Rajasthan does not have a monopoly on patriarchy or the negative effects of it in terms of gender equity. Many, if not all of us outside of India also live in our own exemplars of inequity born of the nexus of patriarchy and racism. So this isn't meant to be that kind of criticism. It's not, in fact, criticism at all. It's just our way of understanding our context so that we can think of ways to help the well-being of the woman that we serve. A second caveat, and is basically the headline caveat, right? We get it in the news, and that's a bias towards negative headlines. So what we found within this particular patriarchal system is that there actually is tremendous potential to intervene based on what's already there, and that's the potential to leverage what was another theme for us, and that is the idea of a good man. So remember, our original motivating idea was witnessing the potential of a local man to act as an agent of change. And that really is what inspired us, because we saw that this older gentleman who was a self-reformed perpetrator of violence could really become a person who was committed to the empowerment of women and through his own experience become a mentor for men. So this is a potential sub-theme, and I'll just kind of illustrate that by saying that I see it every day in Rajasthan. So we see it at our clinic. The picture on the right is a husband taking his wife to the clinic, providing that sort of care. On the right was a screening that we did, and we basically asked this father-in-law to lend us his daughter-in-law for an hour to screen and interview her, and he just basically took the baby and cuddled it for a while. So there is this idea of a good man, and it is local, and it's about kind of leveraging that. I'll just quickly mention some other themes that we had. So these were experiential themes and perception themes. We had themes related to intervention. So we wanted to ask people, like, what were some messages that could change people's minds or behaviors, or help people who are abusing substances, and also who might be good interlocutors for this kind of mentorship interaction, those kinds of things. And I'll just say that our idea of who is a potential agent of change evolved through this. So we thought that, you know, a self-identified former perpetrator of violence could be the ideal person. You know, they learned lessons so they could, through experience, kind of convey these lessons. It wasn't always the case. I think we found one champion who's especially special. But we did find that other people could, who weren't necessarily former perpetrators, but were just older gentlemen who had social capital, could kind of do this work. And this is an idea that we have that we want to test now. This is the next step. So what is the end of this all? And I'll just end this presentation by breaking a cardinal rule of slideshow presentation, especially one that's been kind of picture heavy, and that's put this up, which is horrendous. So it looks really complicated, but I'll simplify this to say that what we've done here is we've identified parts in a married couple's life where there are certain risks. And what we've done is we've tried to identify through our qualitative data where our agents of change who are male could intervene in a really effective way. And what we've kind of come up with here is an intervention that combines the Kushimamta program, so the counseling for mothers, but also really kind of intentional interventions for the husband, and also intentional interventions for substance abuse. And also through this process, we discovered, I mean, I've been working in Rajasthan for 10 years and I had no idea that this group of people existed. This group of healthcare workers called Satins, who are kind of a remnant of a decades old anti-violence program that the government started. And they're there and they could also be a part of this. So I can go into more of this when the time comes. And this was developed, I must say, by Devika Gupta as well, and Abhijit and Urvita. And the next step for us is to really take this and see if we can fund it and test either all of it or a component of it out. But yeah, that's basically, that's the end of the presentation, and I'm happy to talk more about any and all of this.
Thank you so much, Aneel and Soumya and Karana. And Julia, would you like to moderate the discussion?
Sure. That was a terrific presentation from all three of you, and really fantastic work. I'm going to start a question, and then I think there are some in the chat. What were the sort of political economy barriers for men? What were the stressors that they had? Were many of them migrants? What was the sort of wage, issues? Are they, what did you find out about these men as well?
Yeah, I mean, there are a number of things to consider here. One of the things that I brought up in more detail on my anthropology talk on Friday was how this area really has become, it's an extension of the Green Revolution, right? Mm-hmm. So you have indebted farmers, and that indebtedness kind of extends to the laborers, and you have huge inequality between the landed farmers and the laborers, right? So there's all kinds of financial stress going on here. And that was one of the important things that we wanted to address with this, because, the reason why we wanted to have, a female kind of oriented perinatal mental health and gender-based violence program address men is because they're often all suffering from the social conditions that exist. Yeah. And we see this through substance abuse. So I think one of the scandals that exists, and I think that really came forward through or really emerged through the interviews that we did with men, is just the extent of substance abuse, especially, I mean, alcohol is really obvious. I knew that alcoholism was a big problem, but the other problem was opioids. Wow. And I think that, when we think of opioids, we think of it as a North American problem, right? There is an opioid that's of wide use and that's legal and that's really cheap, called tramadol, that is a widespread use here. And so this is not just a North American phenomenon, and I think this is really, really understudied. And the way I think about this is the way we categorize things. Gene Richardson's latest work is about epistemic violence and how we categorize things kind of elides things, makes some certain things invisible for us. One of the things that's really invisible here is the use of opioids as a response to all the stress on men. And the reason it's invisible is because these are not illegal and you can buy them over the counter. And they're actually shipped to places like the Middle East, and they're shipped to North America. So yeah, sorry to go off on a tangent, but all these
No,
things.
but that's interesting. I think that's the, bringing those two threads together, which you've done very well. Looks like there's a question from Amulya Nidi. I don't know if you want to ask that question live, or I can. Amulya asks, what's the government level intervention in this geographic area?
Berna and Soumya, pipe in whenever you feel like it.
Yeah.
So government level intervention for gender-based violence is nothing. There was that SOTIN program, but like a lot of these kind of programs, one government will do it and then the next one will kind of forget about it. And that seems to be what happened with the SOTIN program that I mentioned. With regards to perinatal mental health, there's now more interest in this across India, mainly because of, well, I think frankly, some of the work that Vikram's been doing, kind of proving these models in different settings, and also the impact that work has had on policy. So there's a Mental Health Care Act that has been passed that kind of declares, India is famous for having really kind of progressive policies on the face of it, and then what actually happens is a little different. But the Mental Health Care Act is really progressive and could potentially open up space for more kind of lay counselor delivered work, but it's unsure how it's going to pan out. And maybe anybody else on the call who's a little bit more familiar with the context could talk about that political side of it. But the reality is there's not much as far as mental health care, community-based stuff, or gender-based violence work.
May I add something to it, Aneel?
Yes, please. Yeah.
So the governmental intervention in these gender-based violence-related issues are school-based as well. Rashtriya Kishore Karyakram Yojana, which is aimed towards adolescents and teenager girls to address their issues within the school settings and also in the primary health centers. Other than that, there is a frontline workers cadre, which is SATHINS, as we already talked about it. They were meant to address the issues of adolescent girls, teenager girls, and the domestic violence victims. But sadly, this has become like a monotonous program like the other programs, and there has been no major updates in it. As we conducted an FGD with the community, with these workers, and we realized that they also come with a lot of bias as they come from the community. And their biases are like that if a woman is facing violence with her husband, then they would suggest that you should be able to please him within the bed. Probably then he would not be that violent with you. Or if a 16-year-old girl is pregnant, then the Sathin within that village would suggest that you should rather get married to that 40-year-old man because you're pregnant. And if she's having an affair with someone, then she would suggest, barring the age, she would herself suggest that a girl should take care of her reputation, the pride and honor of the family, and get married to the man if she is in a relationship. So these are the criticisms that we have had for the Sathin program, and also the frontline health workers, ASHAs. They are also given training about for gender-based violence, but they're already so much overloaded with the work and related to health that they hardly care about domestic violence.
Yeah.
So,
thank you. That's so helpful. And I think when you talk about the monotonous nature of these frontline health workers, it is often that just they have training after training and more things loaded onto them, but they're really not that well prepared to do it. They don't get enough resources, etc. I don't see other hands up, but does anyone have a question?
I just wanted to add to what Prerna and Aneel were saying about government incentives. One thing that we also have is one-stop centers for women that are supposed to be shelters where women can go to if they experience gender-based violence. But the biggest barrier is that of access. The closest one to 35 BB was about 60 kilometers away, and then the second one was about 250 kilometers away. And now we're talking about women who barely are able to step out of their houses if they experience violence. So, as such, those spaces are very inaccessible. And also, additionally, not just community health workers, but also doctors and counselors working in health centers and community health centers often try to ask the woman to keep the marriage together and not file a complaint in the police, because if that happens, then there's family reputation at risk. And this is the kind of messaging that's coming from doctors and counselors and psychologists. So there are interventions. India also has one of the most liberal laws for women. But when it comes to implementation of those laws and making these services accessible, that's a huge, huge gap.
Yeah, actually, the major challenge of our program is to be culturally relevant in the sense that we are able to be sensitive enough for the marriage concept within our settings, and also be able to help the women to deal with the violent intimate partners.
Yeah. Yeah, thank you. I see there's a question from Mac, who I believe was one of Aneel's classmates. Go ahead, Mac, and then I think we'll have to wrap up for time. Oh, people might be muted. I'll read the question. From the logistical travel perspective, what helped your CHWs reach the large number of participants that you highlighted in your presentation?
So this was, I think, one of the most astounding parts of it for me, because, I mean, you can tell from the data that we gave with violence is there are a lot of kind of social restrictions around women traveling, right? So even just traveling to the market would be an issue. So I really had no idea how this would work, and the counselors they just made it work. So some of them got scooters and they drove themselves around. Some of them who couldn't drive scooters rode with other people. And then we did have a regular car in use as well that shuttled people around. So logistics in our area was a big issue. There are kind of big spaces between villages, and it is difficult for women to travel, but they made it work. Yeah, it was incredible.
Yeah, great. Scott, I don't know. Are we supposed to wrap up at 1? There are a bunch of questions that came up by 1:05 and beyond. So what's the?
If you and Aneel and Perinatal and Sumia can stay around for 5 more minutes, no one's kicking us out of the room. We can certainly do that.
Okay. All right. Great. I see a question here from Byron. Byron, I don't know if you are able to say your question or. You're on mute.
Hi.
There you go.
Aneel, I was given what you've said about trusting the counselors and what you all experienced about that. I wonder whether you would, in retrospect, use the original version, whether you would maybe do it in a 2-step way after people have had experience, whether, because as you know, and as other work has shown, women's own experience and their willingness to share that experience is a powerful guide in this kind of an intervention. And so I'm just partly thinking about the possibility of adapting this to different settings, such as our work in Indonesia, et cetera. And so really interested in how this has played out and how you think of really formally incorporating the experience of the council.
Thanks, Byron, and thanks for not being sick of my voice after 2 long presentations. So, you're exactly right. What the overall form of the adaptation took was basically going from the really prescriptive peer delivered version back to something more like the original Thinking Healthy program. And the reason that we did that was to kind of just open up the opportunity um, to adjust, right? And so the main idea behind that is that, you know, and this is kind of speaks to my desire to drop the lay in lay counselors, because really they're contextual experts, right? So
Yeah.
compared to compared to a psychiatrist who's sitting in the city, and actually our psychiatrist who we recruited for this program himself told us this when we had to refer to a complicated case. He said that your counselor knows the context much better than I do, and just by that, just by being a woman from the community, being able to pick up on different signals, being able to kind of assess whether something's under threat or whether you can ask for privacy and those kinds of things, really opens up when you let the counselor kind of exercise her will. So the important part about that, and I think, with the no effect of the Pakistan trial of Thinking Healthy, peer delivered, I suspect, and I want to talk to the people who actually implemented this, but it seems like they had a really short training time. Whereas in India, it seems like they had a longer training time. And we really extended out our training because we wanted to make our counselors comfortable. And it went from just being able to sit face to face with somebody and being able to say your name and ask a question, because people, like, women, especially younger ones, don't really do that, and to build that counseling instinct. And that takes time. And I think if you start with the more prescriptive version, you don't let those instincts develop. So on the one hand, I think that the motivation was to just make it prescriptive, make it easy, like give algorithms, give charts. But when our counselors arrived at some houses and the roof is collapsing and the husband's drunk and the wife, we had a case where a mother was on her way to commit suicide and kill her children. Right? She was in that kind of a state. And what's an algorithm going to let you do in that situation? So I think you extend training and you kind of prepare them as best you can. The other side of that, though, is the ethical dilemma that I mentioned before. Is like, should we keep putting our counselors in that situation? But yeah, I hope that answers the question, Byron. And thanks for the question.
And I see Jane West has a question, and then after that, we're going to wrap up. You need to unmute.
Sorry, I have a wayward cursor and it goes wherever it wants. So can you hear me now?
Yes.
Yeah. So I'm just wondering, I know you shared a case last week that dealt with a lot of underlying issues in a counselor and how they were able to surmount that. But overall, I'm wondering if you have any idea when you hire or it emerges in training that there are things like unresolved loss, trauma, and how that in general manifests and what the current supports are. And I know that's a big question and you have a little bit of time. So you and I can talk later, but just maybe a quick reply would be great. Thank you.
So maybe Soumya and Prerna can pipe in about what I'm about to say, but I feel like in this setting, it's impossible for a woman to not have experienced trauma, right? So you're just not going to find a counselor who doesn't have her own issues to work through. And I think what happened in our training is that became a part of the training. So they were able to talk to each other and kind of start up this kind of internal counselor support supervision group. And that's kind of how we dealt with it. So I want to formalize those thoughts and write this out a little bit more. But one of the things I was most grateful for as a man who's, you know, North American and really an outsider is how we got to the place in training where my counselors would trust me with really personal details about their personal lives and their problems with childbirth and depression and things that they just didn't talk to anybody about. So I really think the key is to know that you're going to have people who have their issues, but then that might actually make them really good counselors.
Yeah.
To
May
add
I
to
add
that,
something?
I think we're going to have to wrap up now. But thank you, Aneel and Priyana and Sumya for a great presentation. Really wonderful to hear and poignant.
Thank you. Thank you so
Thank
much.
you all.
All right. Thank you.
Have a good day. Bye.
thank you. Bye.